Hello everyone, welcome back to this video. So in this video, we will be learning about hypoglycemia in neonates, how to manage in NICU, right? So starting off with hypoglycemia, the first one is definition, right? When we need to tell whether it is hypoglycemia or normoglycemia or euglycemia, right? So hypoglycemia is defined as when blood glucose level is less than 45 milligram per deciliter. But there are other certain criteria such as when blood glucose levels of less than 40 of VSL and plasma glucose level of less than 45 milligram per deciliter, we called it as hypoglycemia. So screening for the hypoglycemia, in which all patients do we need to screen? What are the risk factors? So in considered neonates as genetic syndromes or congenital hyperinsulinemia, one of the most common patients or babies where we need to screen hypoglycemia. Apart from that, the certain risk factors indication for routine blood glucose monitoring requires when the weight of the baby is less than 2 kg, gestational age is less than equal to 35 weeks, HGA babies, infant of diabetic mothers, and with RH hemolytic disease, and neonates receiving therapy such as terbutaline, propranolol, or some other drugs, right, which has interactions with insulin. And then sick neonates, of course, we need to monitor sick neonates, BSL in every patient. This is such as asphyxia, polycythemia, sepsis, underlying cause infection, inflammation, family history of genetic form of hypoglycemia. And then congenital syndromes such as Beckwith-Wiedemann syndromes, Sotos syndromes, Kabuki syndromes, and neonates on prolonged total parenteral nutrition or post-surgical neonates, right? So how often we need to monitor the blood sugar level? If patient is at risk, then we need to, or a baby of infant of diabetic mother, or there is requires continuous monitoring of the glucose, then we need to monitor every 2 hour, 6 hour, 12 hour, 24 hour, 48, 72. And then at 72 hours or in the multiplication factor of 2. If the baby is sick neonate such as asphyxia, sepsis, infection, inflammation, then every 6 to 8 hours is okay in 24 hours, right? And if the baby is on parenteral nutrition, then initial 72 hours, every 6 to 8 hours, and then after 72 hours, then once a day is fair enough. And in which patients do we not need to monitor sugar? Infants who have AGA, appropriate for age, or they have appropriate weight of the accepting and tolerating feed, and there is no events or episodes of hypoglycemia, then it's not necessary actually to monitor the glucose levels, right? And then symptoms of hypoglycemia, how baby presents in hypoglycemia. This is important, right? So let's learn this. So there are basically two types, neurogenic and neuroglycopenic. Neurogenic symptoms occur due to sympathetic nervous discharge triggered by hypoglycemia. Whereas neuroglycopenic symptoms result from deficient supply of primary fuel, that is from liver, glucose to the brain. So clinical signs include stupor, jitteriness, lethargy, tremors, apathy, episodes of cyanosis, convulsion, intermittent apneic spells most of the times, right? Tachypnea, high-pitched cry, or difficulty feeding most of the times. So episodes of sweating, pallor, hypothermia, cardiac arrest have also been reported in some cases. So for diagnosis, they are classified on the basis of two criteria, that is asymptomatic and symptomatic. So asymptomatic means when the blood glucose level is less than 40 milligram per deciliter, confirmed by lab investigations, and the infant does not manifest any of the above symptoms, right? Whereas symptomatic hypoglycemia is where blood glucose level is less than 40 and associated with the above symptoms such as difficulty in feeding, lethargy, stupor, coma, or something other which is very serious for the baby, not level CNS is involved basically. So that are all the things, we classify as symptomatic and asymptomatic. So for management of asymptomatic hypoglycemia, the first is feeding, give feeding, see whether hypoglycemia resolves or not, doesn't resolve, right? So direct breastfeeding is the best option for the trial of the oral feeding. Infants, if the infant cannot suck, or expressed milk may be given. Breast milk problem is that the main important of breastfeeding is that it promotes ketogenesis, right, which acts as a fuel for the brain. So ketones are important alternative for the brain, right, along with other sources such as pyruvate, free fatty acids, beta hydroxybutyrate, or amino acids. If breast milk is not available, then only we can give top feed. Recently, they have updated with the buccal dextrose gel, right, which we keep in the buccal area so that it promotes or relieves symptoms temporarily of hypoglycemia. Right? Apart from that, if the baby is symptomatic hypoglycemia, then the main treatment is IV glucose D10. We give a bolus of 2 ml per kg we give a bolus of 2 ml per kg, right, of D10. That is maximum dextrose we can give is 200 mg per kg. And look for the seizures or associated symptoms, right? The bolus should be followed by always glucose infusion. Don't give just bolus and continue IV fluid. The bolus has to be followed by infusion at a rate of 6 to 8 mg per kg per minute. If still the persistent hypoglycemia is there, then we can need to add glucose infusion rate, right, at the rate of 2 mg per kg per minute, and then increase subsequently in the next 15 to 20 minutes. That's what it is written, right? If BSL stays still below 50 milligram per deciliter, then GIR we need to add, which is increased every 2 to mg per kg per minute, right, until a maximum of 12 mg is reached. So this is the algorithm, right, for hypoglycemia. So hypoglycemia is when blood glucose level is less than 40 milligram per deciliter, is classified as symptomatic and asymptomatic. So if let's talk about asymptomatic first. If asymptomatic, whether the level is between 20 to 40 or less than 20. If there is 20 to 40, then we give trial of the feeding, oral feeding, and then monitor after 1 hour. If it is still more than 50 or less than 50, right? If that's increased above 40 after feeding, then frequent feeds, monitor blood sugar every 6 hourly, stop after 48 hours. Before discharge, ensure there is no evidence of hypoglycemia and the baby is accepting and tolerating feed. If after feeding the blood glucose is still less than 20, then we need to give IV glucose. That is basically it is considered under symptomatic hypoglycemia, right? Bolus of 2 ml per kg of D10 is given, followed by glucose infusion at a rate of 6 mg per kg per minute, and monitor the euglycemia is achieved. After that, while monitoring, if the blood glucose level is more than 50 or less than 50, on the basis of the diagnosis it is classified. If it is more than 50, it means glucose level has increased after giving bolus. So if it is stable for next 24 hours, then we taper IV infusion rate and start feeding, weaning by 2 mg per kg per minute every 6 hours, and increase oral feeds, monitor glucose every 6 hourly. Stop IV fluids when rate is reached 4 mg per kg per minute, and then infant is stable hemodynamically, right? Stop monitoring when two values are more than 50 milligram per deciliter throughout the monitoring process. Even after bolus D10 of 2 ml per kg, the glucose level is less than 50, then increase the glucose concentration at the GIR by 2 mg per kg per minute till euglycemia is achieved. Increase glucose till 12 GIR is reached, right? If still hypoglycemia is persistent, we refer to the endocrinologist and look for the underlying cause, and then what else or drugs we need to add, such as hydrocortisone, diazoxide, glucagon, octreotide we can add, but there are certain contraindications that we don't add in every patient, right? So yeah, that's it. And then another term that is called as recurrent or resistant hypoglycemia, when even after GIR of more than 12, the hypoglycemia is persistent, right? In such cases, we need to remove the critical samples. So what are critical samples? Serum insulin level, C-peptide level, IGF-3, serum cortisol and growth hormone levels. For ammonia, lactate, free fatty acid, beta hydroxybutyrate levels, or we can send GCMS, TMS, right? GCMS, TMS. We need to do for the other inborn error metabolisms, right? Urine ketones, urine reducing substances, or GMS. So for resistant hypoglycemia, the treatment of choice is first choice is always hydrocortisone, which is given as 10 mg per kg per day BD. Basically, it aims to reduce glucose at the peripheral level. So reduces peripheral glucose utilization, increases, promotes gluconeogenesis. Side effects of hyperglycemia and hypertension. So diazoxide, octreotide, and glucagon are the other drugs which are given for persistent or resistant hypoglycemia. And another term is a GIR. How should we calculate GIR, glucose infusion rate? So percentage of the dextrose infused into rate upon body weight into 6. That is this shortcut formula. D into R upon 6 into weight. Dextrose into rate of IV fluid upon 6 into weight of the baby. Infusion rate is IV rate into the percentage of dextrose content upon 144. That is dextrose percent. That is a 5% dextrose or 10% dextrose into rate of the IV fluid upon 144. Right. That's it. If you want this PDF, then DM me or message me or comment below. I will send you PDF. Thank you.